morning, good afternoon, and good evening to all of our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome back to another episode of very educational lectures for you. The speaker for the first session of today's webinar is our honored guest from India, Professor Suhas Udaykumaran. Professor Suhas is a professor in the Division of Pediatric Neurosurgery and Pediatric Craniofacial Surgery at the Amrita Institute of Medical Sciences, Amrita University, Cochin, India. He completed his specialization in neurosurgery from the King Edward Memorial Hospital, Mumbai, and thereafter his subspecialization in pediatric neurosurgery at the Dana Children's Hospital, Tel Aviv University, Israel. He has more than 50 international publications in peer-reviewed journals, book chapters, and number of international conference presentations. He is involved in multiple research projects in neurosurgery in association with the Amrita Center for Neurosciences and Molecular Biology. We are extremely honored to have him today as a speaker at our webinars, and today he will be talking about simplifying craniosynostosis. The speaker for the second session of today is our honored guest from China, Professor Yang Lu. Dr. Lu is a neurosurgeon with Tsinghua University affiliated Tsinghua Chang'an Hospital in Beijing. He graduated from the 8th year clinical medicine program of Southern Medical University and a postdoctoral fellow of the Tsinghua University. He won the title of Beijing Nova program, presided over a project of Changping National Laboratory, and participated in a number of national, provincial, and ministerial level projects as the backbone, such as National Key R&D Program of China in the 13th Five-Year Plan. He is dedicated to translational research on the regulation and reconstruction of spinal cord function. We are extremely honored to have him today as a speaker at our webinars, and today he'll be talking about spinal cord stimulation, neuromodulation from sensory to motor function. The chair for the first session of today's webinar is our honored guest and senior faculty from Taiwan, Professor Mu Li Liang. Professor Li Liang is a senior pediatric neurosurgeon at the Department of Neurosurgery and as assistant professor at the Department of Medicine, Mackay Medical College, New Taipei, Taiwan. He is also the chairman of the Pediatric Neurosurgery in Taiwan Neurosurgical Society. He was the past president of the Taiwan Society for Pediatric Neurosurgery and supervisor of the Taiwan Society for Neuro-Oncology. He specializes in the surgery of pediatric brain tumors, vascular diseases, craniovertebral junction instability, congenital anomalies, and complicated hydrocephalus. He was a previous fellow at the Department of Neurosurgery at the Hospital for Sick Kids at Toronto, Canada. He was awarded the Excellent Teacher Award for his dedication and excellence in teaching at the National Yang Ming University and Excellent Teacher for residency training in Taipei Veterans General Hospital during his services in this institution. We are extremely thankful to him for accepting our invitation to chair the session of Professor Suhas Udaykumaran. The chair for the second session of today is our distinguished faculty from Japan, Professor Takashi Agari. Professor Agari is a consultant neurosurgeon and medical director of the Department of Neurosurgery, the Tokyo Metropolitan Neurological Hospital, Tokyo, Japan. He specializes in functional neurosurgery as an integral part of the Japanese Society of Stereotactic and Functional Neurosurgery. He has several articles in various peer-reviewed journals to his credit. We are extremely thankful to him for accepting our invitation to chair the session of Dr. Yang Lu. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers and chairs and the audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely thankful to Professor Shubin for broadcasting this on the WeChat channel. Dr. Liu Boon Singh from Malaysia is my co-host for today, and with that introduction, I would like to hand over the podium to our first chair, Professor Mu Li Liang.
Okay, thank you, Raja. And thanks for the Professor Yoko Kato, the president of ACNS, for the invitation. In the ACNS webinar, we are very happy could still have a lot of very instructive lecture addressed by the distinguished speaker during this COVID-19 pandemic period. I'm Mu Li Liang from Mackay Memorial Hospital, Taipei, Taiwan. I will share the topic about the craniosynostosis. As we all know, the surgery of craniosynostosis should be individualized to different type and age. The techniques have steadily evolved with the advancement of craniofacial surgery for decades. The identification of the key aesthetic and functional issues have been more and more emphasized recently. For the treatment of syndromic craniosynostosis with craniofacial and synostosis, it is more complex. So today we are very honored to invite the speaker of first topic, Professor Suhas.
Thank you, Professor. And I thank the scientific committee of the ACNS for this opportunity. I think I'll also extend my congratulations to the system working such a perfect way that the way you're contributing to this academics of the world around. Okay. So I'll start the topic. My theme is a symphony etched on the bone and the mind. We know that craniosynostosis is such a complex entity, and these children are so complex that multiple specialties come together to create to give quality to this quality and great function to these kids. So my talk is on the algorithm for these complex craniofacial anomalies. We know that there are multiple specialties involved, multiple techniques involved, and multiple situations involved, and these have to be brought together towards in intent to give a great long term for these kids. So there are multiple varied presentations: the raised ICP, the proptosis, subluxation, orbital subluxation, snoring, sleep disturbance, recurrent URTI, failure to thrive, and there are multiple surgical procedures, and multiple specialties come together to give to deliver all this. You have the neurosurgeon, the maxillofacial surgeon, the plastic, ophthalmology, orthodontic surgeons, psychologist, pediatrician, and together it's a very complex anomaly, and the algorithm itself is very complicated. I'll try to create some kind of a differentiation of how we deliver our algorithm towards the betterment of these children. So we identify 4 parameters apart from the clinical, of course. And the clinical I'll elaborate in later part of the talk. We do a MDCT for the children, a multidimensional CT, where we look for the suture involvement, the single suture or the multiple sutures. We look at the MRI to look for the Chiari and the hydrocephalus. We do a sleep study if we think that the maxilla is involved, and as I mentioned, to look for the obstructive and the central apneas. And in the clinical parameter, we look for the raised ICP, the airway and the ocular involvement, both demonstrating the max involvement of the maxilla. Aesthetics is usually involved in all these kids, and there are of course other issues that are involved. I mean, so the basic questions which we ask when we have such a kind of kid is there a sign of raised ICP? Is there an airway involved? Are the aesthetics involved? And of course, we pick up the other functional issues. As I mentioned, we do the following investigation: the MDCT, the MRI, and the sleep study. And we categorize them into 4 situations. One where is raised ICP along with the presence of Chiari. The second situation is where you have ICP with or without aesthetics, and then you have the airway and ocular involvement, and along with the aesthetics, and of course the other functional issues. So the posterior calvareal wall distraction has been considered nearly a constant accompaniment for children with syndromic craniosynostosis. So we start off with posterior calvareal distraction, and especially if hydrocephalus is present, you have an option of doing shunt, but we try to avoid shunt in these kids. And then the frontoorbital advancement remodeling is sometimes used in older children, and when the ICP is mild. Whenever airway is involved, we try to correct the airway issues, usually by midphase destruction. Of course, the other situations where after a fibroendoscopy, we identify different other locations can be handled differently, like the mandible, adenoid tonsillectomy, etc., etc. And very occasionally tracheostomy. You'll see that our algorithm does not involve tracheostomy. And then, of course, the other issues like hand surgeries and the orthodontic procedures. So usually we start off with posterior calvareal distraction with or without shunt or endoscopic third ventriculostomy. FOIR is used in older children or sometimes as a primary surgery. And the midphase is usually involved, usually addressed after the ICP is addressed. And then, of course, other surgeries have a place in beyond these 2 primary goals. So, we have a small we have a protocol where we categorize these children into four categories. Where the category 1 we have the non-syndromic and the single suture ones, where only aesthetics is involved, and usually it's the surgical options are frontal-orbital advancement, and we keep hypertelorism correction in this category. So this categorization is basically to transfer information across the multiple specialties that are involved. Then we have the category 2 where only the ICP is involved. So these children on the MRI might have hydrocephalus and Chiari, and on sleep study, because of the presence of Chiari, they might have central apnea. And here, the posterior calvaire wall distraction is the primary mode of surgery, and occasionally shunt comes into play, and with or without frontal-orbital advancement. Then you have a third category where airway is usually involved. ICP is not predominantly involved. Of course, this is very occasional. When along with the airway, the ocular involvement is highly possible. That is, they might have proptosis, they might have subluxation. So here, because the airway is involved, you might have an obstructive component in the sleep study. MRI is usually normal, and aesthetics are usually involved. So here, these kids, because the aesthetics involved, you do a frontal-orbital advancement, and midphase is addressed. Midphase is addressed very commonly. Of course, the other forms of airway correction is also once in a while done. Tracheostomy is not involved in our protocol. The next category is where airway and ICPs both are involved, and this might have on the MRI might have hydrocephalus and Chiari. A sleep study shows central or obstructive sleep apnea. Aesthetics are usually involved. And here comes the whole combination of surgery: the posterior calvaire wall distraction, front orbit advancement with or without shunt once in a while, and midphase distraction. Our category 5 involves delayed presentation, where usually the aesthetics are involved, and we correct only the specific issues that these kids. So it's a problem-specific addressal for whatever these kids present with. Of course, I'll elaborate in the future slides too. So if you notice, the complexity is changing across these categories, and between 1 to 5, the category the complexity is different. We refer to 5 to as a complex one because these children because they present with such a delayed in a delayed way. Their performance, everything is affected, and the prognosis is poor. So the treatment workflow works across like this. You have a you pick up the clinical picture, you do the MRI, sleep study, and you create a surgical strategy. And you realize that the functional prognosis is also changing across the categories. So, as I mentioned, again, I'll reiterate, we have the basic concept of looking at the ICP, look at the fontanel, papilledema, hydrocephalus, look for the presence of hydrocephalus, and look for presence of Chiari on imaging. And then you have look for the airway issues, apnea, snoring, and snoring secondary to central apnea or obstructive apnea, recurrent URTIs, failure to thrive, severe proptosis, exposure keratitis, and subluxation of the orbit. So this is I'll summarize the categories. You have in category 1, you have only the aesthetic issues, and the surgical modalities used are frontal orbital advancement, hypertelorism correction, and some kind of calval remodeling. In the category 2, we have the raised ICP, so you have the posterior calval wall destruction, and you have the frontal orbital advancement. In category 3, you have the airway issues, and ICP is subtler than the category 2, where the ICP is the much prominent one. So here we use the frontal orbital advancement because the aesthetics are involved, and midphase because the airway is involved. The category 4 is where ICP and airway both are involved, where all the complete battery of calvareal surgeries come into play. The posterior calvareal wall remodeling, front orbital advancement, maxillary distraction, and other airway maneuvers, and other functional issues are tackled. And as I mentioned, category 5 is where you have the delayed presentation, where you address only the specific issues. So I'll take you through different scenarios. This is a category 1 where you have only pure aesthetic surgery. We call our technique the geometric correction of non-syndromic craniosynostosis. Like to give you an example, this is a classical kind of plagiocephaly. You have the classical C-shaped deformity of this face. You have the ipsilateral deviation of the root of the nose, and you have the reduction in the height of the ipsilateral maxilla, and you have the tilted occlusal cant. So instead of eyeballing, we have a mathematical way of eyeballing, where we try to identify a tentative midline, because the midline is unclear in these children. We keep the mandible as the possible midline, and what we essentially do is, this is the geometric correction, where we essentially look at the opposite normal side, and that epicenter is used to recreate the opposite side. So this is what we call as geometric correction. So essentially, we are trying to correct it according to the normal side. So if this is normal side, this is the epicenter of the forehead. We try to look at how much discrepancy is there on transverse, vertical, and the depth, and that is used for correcting according to the opposite side. So this is the front. This is the geometric correction. So that basically the normal forehead is mirrored onto the opposite side. Basically, and this is done on 3 dimensions, in 3 dimensions. So this is what we call. So this is the normal side. This is the abnormal side, where we have a discrepancy transversely, vertically, and anteroposteriorly, which is corrected on the correction which we do. So this is referred to as the geometrical correction of the forehead. So that's a child going undergoing child with plagiocephaly undergoing geometric correction. So this is the forehead. This is the caudal aspect. This is the forehead. So and this is the bando, and we have fixed it with the resorbable screws. So this is the child with the plagiocephaly. You can see the CT with the abnormal coronal suture. So this is the child after correction. You can see the corrected forehead. The plagiocephalic child, and this is the corrected one. So this is the same technique being used for metopic correction. A slightly older child, 1 year old. The same correction. All the bones are manipulated according to our methodology of geometric correction, and we use all resorbable plates and resorbable suture material. So that's what we have achieved on after correction. So this is our pre procedure, and this is the post procedure. So that's what we have achieved post correction. Occasionally, we use springs for metopics, because there's an element of hypothyroidism, and so here we have used springs to correct the hypothyroidism. So this is the pre-op, and this is post after the distraction happening with the springs. This was our publication which highlighted the use of springs for metopic craniosynostosis. So this is a baby with metopic. You can see the pre-op pictures, and this is at 3, 6, and when we go for removing the springs, we sometimes correct any residual deformity. Like this child had gentle amount of temporal depression still, and that we have corrected it in this. And so that's the final picture of this child after the correction, after the spring cranioplasty plus a gentle FOA. So the idea of using springs in these children is to improve the results outcome of the hypothyroidism. This is the same geometric technique used for brachycephaly. You can see that how the transverse diameter is reduced and the anteroposterior diameter is increased. So that's the baby on after correction. Encephalocele and hypertelorism correction comes in our first category, where only aesthetics are involved. So this is a child with hypertelorism and encephalocele. So you have increased intercanthal distance and a deviated nasal septum. And that's him, and that's his MDCT. So that's his encephalocele. So classical neurosurgical correction, where you correct the encephalocele, remove the encephalocele, the dysplastic tissue, repair the base with the pericranium, and do a box craniotomy for the front the orbit. So that's his pre-op, and that's his post-op. So you have a neurosurgical correction and the correction of the hypertelorism. So that's him post-surgery. So for us, the revision surgeries for aesthetics comes in our first category. Here's a 15-year-old boy who has been operated for craniosynostosis 2 times, and he still has a residual deformity, and he was concerned about his quality. So that's him on his MDCT. You can see all the previous previous materials which has been used by in the previous surgeries elsewhere, and the bone. So in the previous surgery, they had used PMA, the bone cement, to correct him. So that's his calvarium. You can see the changes on his orbit and his plagiocephalic effect. So that's him intraop. You have the old bone cement sitting there. So we corrected it with a kind of front orbit advancement and some kind of some additional hydroset, which is a additional bone cement to correct his forehead. That's it intraop image with post correction. That's his intraop image. So this is him post correction. You can see the correction of the flattening and the esotropia. This is what we have got post correction. You can see how his forehead is formed after correction. So this is a craniofrontal nasal syndrome, CFNS syndrome, where you have the craniosynostosis, facial asymmetry, hypertelorism, and a grooved nasal tip. And you can have additionally cleft lip and palate and various other skeletal anomalies. This is inherited X-linked. Again, this has only aesthetic significance. That's why we have put it in category 1. Usually a classical EFNB B1 gene anomaly. So that's him. I mean, this is a part of the TCS cleft anomalies. So here we have done a box craniotomy. So that's intraop. There's an excision along with the box craniotomy. There's an excision of the excess of skin. That's him post surgery. That's his post surgery. This is a much more complex facial cleft along with the cranium involved. So there's a malocclusion. There was a malocclusion of the maxilla. So you can see it's another kind of TCS cleft. So this is a facial bipartition where the cranium and the face is addressed in the single go because there's a malocclusion at the maxilla. So this is facial bipartition where you address the forehead because there's craniosynostosis. Then you address the face by doing a facial bipartition. So that's the child post correction. That's post correction. In our category 2, we have the aesthetic issue along with the raised ICP. So the choices are posterior calvary wall distraction and front orbital advancement. So this is one scenario where it's raised ICP and no Chiari and without no hydrocephalus and no airway issues. So only ICP is involved. So this is a complex kind of scaphocephaly, not a straightforward kind of scaphocephaly with multi-suture involved. This was a 1-year-old boy with papilledema. So you can see the multiple sutures involved, the dolichocephalic head with the sagittal suture involved and the coronal suture involved. So basically, it's a dolichocephalic head with raised ICP. So this is his post correction. You have corrected the anteroposterior cephalic index. That's some post correction. This is post correction, and that's him on this long-term follow-up. So another situation is as you sometimes get a raised ICP along with this aesthetic issue. This also comes for us in category 2. So this was a 5-year-old appert who was operated when he was at 1.5 years old. He had a new onset papilledema and a new onset headache. So this was his MDCT showing the previous surgery. So he was an appert with recurrence of symptoms. So that was his calvarium with bone defects, probably because the raised ICP had not closed off. That was from his previous surgeries. So that's his intraop image. Again, the classical front orbital advancement with the Mando. And that's what we have achieved in him. His midface needs to be addressed separately, but we have corrected his forehead. He needs a midface correction later in life. We usually try to postpone as much as possible unless there are airway issues. Of course, I'll come to that in next few slides. So that's him with his forehead corrected. You can see the advancement that we have achieved. So our category 3 is where airways is associated with aesthetics. So here, because the aesthetics are involved, you need to do a frontoorbital advancement, and maxilla, midface, or mandible needs to be addressed for the airway. Here, the sleep study is one of the key important determiners. So this was a Cruzen with a very mild ICP issues. He did not complain of any ICP related complaints. So he did not have papilledema. But his midface was involved, and he had recurrent episodes of URTI. So here we have used multiple internal distractors, the Marshak and the Arnaud. This is on the STL model. You have the Marshak and the Arnaud for internal distractor, because he has his aesthetic need to be corrected and his airway need to be corrected. So that's this forehead, and this is the barrel sleeving posteriorly. So this is what we have achieved in him. You can see the midface that is advanced, and his forehead, which is advanced along with the midface. So this is pre-op, and this is post-op. His symptoms regressed, but recently, after his 5 years follow-up, his midface symptoms have reappeared. So he's planned for revision midface surgery. This is an older child, again, with only airway involved and no ICP issues, never treated in the past, Cruzen syndrome. So being an older child, she was about 15 years old. So being an older child, the classic surgery, of course, is the monoblock advancement, which has its own pitfalls, including meningitis and high morbidity. So we use a distraction, which is the current standard of care. This is a external distractor, red distractor. So here we have distracted her forehead and the midface using a single construct. So that's what we have achieved on an X-ray, and the forehead and the midface has come forward. So you can see the reference of incisors as showing the movement. So that's what we have achieved in her post-op. Her eyes have gone, eyes are well placed, orbits are well placed, forehead is forwards, and the midface is much better. So our category 4 involves where ICP and airway both are involved along with the aesthetics. So we have a possibility of doing a posterior calval remodeling in the youngest, and the frontoorbital advancement in the older children, or after PCVD, and in the midface distraction. So this is a child who was 11-month-old who came with full fontanelle, hydrocephalus, and Chiari. So there's a combination, and is a classical Cruzen. So he had ICP issues along with airway issues. He's 11-month-old. So you can see the Chiari and his both the lambdoid sutures involved and the coronal sutures involved. So he's a multi-sutural craniosynostosis with signs of raised ICP and a classic Cruzen. So therefore he has airway issues. So this category involves both ICP and airway issues. So here we started off with the posterior calval distraction. So the classical posterior calval distraction, the planning of the flap, and the posterior calval distractor being placed. Here we did a supratorcular kind of craniotomy. We did not go below the torcular. That was our initial kind of surgery. Later we started going below torcular too. So that's his placement of the posterior calval distractor. And the foramen magnum was decompressed too. So that's what we have done in him. So as just to highlight, and the posterior calval distraction improves, reduces venous hypertension, probably reduces the development of hydrocephalus, reduces central apnea, and increases cranial volume much more than anterior advancement. It's probably a shorter procedure and more tolerated by the youngest of this lot of complex craniosynostosis, and has lesser blood loss, hence preferred early in life. And it probably prevents further terucephalate development if done in very early in life. So this was him after the posterior calval distraction. So his frontal orbital advancement is pending. His midphase needs to be addressed too. So this is his after his posterior calval distraction. You can see the increased space in the cisterna magna and the reduced tightness of the foramen magnum. So his midphase is addressed second after this. So we use a robot to do a transmaxillary pin. We use a robot because this reduces the disadvantage of going blindly and avoiding damage to the orbit and the molars. So this is a ROSA, which is being used to guide the transmaxillary pin. So this is the transmaxillary pin going across, and this is the same on an STL model, and here we have passed the transmaxillary pin for his midphase distraction. So this is for a frontofacial advancement. We advance the forehead along with the midphase to improve both the airway and to improve the aesthetics. So this is what we had published in Neurosurgical Focus about in the beginning of this year. We had about 18 kids where we did a frontofacial advancement using robotic assistance. The advantage is we advance midphase very early in life, including infancy, and the second advantage is we avoid tracheostomy in these kids. And of course, give functional benefit to this kid without waiting for them to grow older. So that's his midphase advancement. You can see the difference in the forehead and the midphase. This is frontofacial advancement. So this is sim post-surgery. So again, this is another child who a 3-month-old who had severe failure to thrive and severe Chiari. This was an Antley-Bixler syndrome. So he came to us with hydrocephalus. So I started off with endoscopic third but he developed a leak, and from there onwards I had to go for shunt. Because he had severe failure to thrive, I did not have a choice but to use endoscopic third and shunt. But we did, of course, endoscopic third ventriculostomy is mentioned in craniosynostosis for use in hydrocephalus, but has a failure rate of over 30 to 40%. So, probably because the hydrocephalus in these children are multifactorial in entity. So that's his calvarium with the lacunar skull. He underwent a shunt, and that's his calvarium with lacunar skull. This posterior calvarium where both the lambdoids are completely involved. He underwent posterior calval distraction. These are just to show the distractors. Posterior calval distraction, and that's his posterior calval after distraction. You see the improvement of the cisterna magna, and he had a foramen magnum decompression too. So that's his posterior calval distraction. So he had after the posterior calval distraction, he had severe airway issues. So our question was to do a tracheostomy versus midphase distraction. So I told you in the beginning itself that we prefer a midphase distraction, and we have avoided tracheostomy in all these kids by doing a monoblock. The midphase maxillary pin, transmaxillary pins using robotic assistance. So this him after his frontoorbital advancement and the midphase transmaxillary pins. He developed macrocephaly at this instance, and I had ligated the shunt before doing the posterior calval distraction. Now I had to reopen the shunt again. So he underwent a shunt after this procedure again. So that's him after before us. So that's him after his correction. So again, he underwent a programmable shunt. So the options of management of hydrocephalus is posterior distraction, ETV, or programmable shunt. Then you have a situation where you have an ICP and airway issues in an older child, without Chiari in hydrocephalus. So this was an older Cruzen's child, never operated in the past. So you have an option of either you can do staged management of the forehead and the midphase, or you can do a monoblock, or you can do a frontofacial. So this is again the monoblock distraction. So he underwent a monoblock distraction of the forehead and the midphase together using internal distractors. So that's him post-surgery. You can compare his orbit, midface, and the forehead. So his airway signs improved. He had ICP issues too. So he has ICP issues and airway issues. So this category involves both ICP and airway. So both were addressed together. Our category 5, as I mentioned, involves all children with delayed presentation. We call this delayed because they are already damaged in their performance, and their issues are we address only very specific issues in these kids. So this was a 17-year-old untreated cruisans who came to us with this Chiari and this syringomyelia. So she had difficulty. She had suboccipital headache, and she had difficulty in walking in terms of ataxia. So she underwent only foramen decompression. She did not undergo any other surgery because she's 17-year-old. She was already disturbed or damaged in her performance, and because her presentation was only spinal, we addressed her foramen magnum rather than addressing her other issues. Of course, you can give them a choice to correct the forehead and the midface, but because they are completely disturbed in terms of performance and psychology, we tend to discourage very active, aggressive treatment in these kids when they present very in a delayed way. This was an Aperts, a 15-year-old Aperts. Again, his concern was his aesthetics. So here we offered him a red distraction of the frontofacial aspect. So that's him after correction. He's an Aperts. His performance was severely affected. So the primary goals in him was only aesthetics. So that's him post-surgery. So I have in the last few many slides we have I have gone through different categories, created different categories to deliver the results, and we have a definite algorithm in place to make the whole complex scenario of complex synostosis into in a simplified form. And I don't need to elaborate that delivering aesthetics, maintaining a sane psychology, and maintaining a good performance is a continuum which is delivered together by all the specialties together. So if I have to summarize, age and presentation are key to the outcome and decision making, and the goal is to avoid the goal of these surgeries are to avoid secondary damage. So the functional performance should be a key yardstick for the goals and analyzing treatment outcomes. The science of craniofacial surgery is at a crossroads. The technical aspect of surgery alone is only a part of the whole thinking process. And what we do as pediatric neurosurgeons or neurosurgeons in terms of quality, preserving and improving the function, the part of the main part of surgery is actually a very small part of the whole issue. Thank you. Thank you.
Professor Liang?
Yeah.
Kindly unmute your mic, Professor Liang. Please unmute again. I accidentally muted you. Professor Liang, kindly unmute again.
Okay.
Okay.
Okay. Thank you, Professor Udayaku Maran, for your great talk and a very fantastic surgery for this very difficult syndromic craniosynostosis. So right now we have opened for the question for the online audience. Is there any question?
We can invite questions. If I may start with me, first of all, let me congratulate you for the wonderful work that you have been doing there in your place and helping those very needy children, giving them a quality of life and happiness for the parents. Congratulations, first of all.
Thank you.
I would like to inquire with the professor that many of these children, as we are some from the same place of where I am, they come late to the referral center like yours. So I just would like to inquire how late is too late. I believe that the categories you showed may be a progression from lower category to higher as they grow. So, what is the best time for correction when you observe a syndromic craniosynostosis?
Now, if you look at it highly theoretically and functionally, you should. We need to understand that the damage is ongoing from the antenatal time, isn't it? The first 3 months of life, the brain is already a formed organ, and this damage is ongoing. So if you look at it ideally, you need to move as fast as possible. So that you need to balance with the safety of any kind of surgery which you do. So that's why the endoscopic suturectomy with plus the posterior calvary vault distraction in very early in life has a very great place. And it's probably a revolution in terms of improvement, because they are minimally invasive, minimal disturbance to their general functionality, and at the same time delivering high optimal conditions for the brain to catch up. When it comes to the upper limit, I mean, we do understand that the brain growth maximally happens within the first 2 years of life, and probably happens until around 5 years of life. So you need you need to do it as early as possible, but you should not deny treatment during this period, because I've seen dramatic improvement even at later age. And once in a while, they come with severe visual issues, visual symptoms, and including losing vision. And that time, no time is late. You have to do it at any stage when they come to us. And although the techniques are much different when you have an older child, as you saw in the presentation.
You rightly mentioned about vision. I would just like to inquire, how do you test the vision and look for papilledema in such small childrens?
The clinical suspicion is the key to the decision making here. You have a low threshold for diagnosis and treatment in these children. Papilledema per se is not relied upon. Naturally, because as you said, identifying papilledema has its own limits. And so we look at the clinical scenario. You have a Cruzen's child who comes with a diagnosed Cruzen's child on phenotype. You need to deliver. That the ICP is going to be an issue. The vision is under stress, and the brain is under stress in terms of damage. So we do not look into the objective evaluation of all this, although we do it as a part of our evaluation, including sleep study. We treat the ICP as early as possible. And if they have obvious snoring, repeated URTI, and sleep study showing abnormal apneas, we proceed for airway correction too.
And as you said that currently you are doing a posterior calvary distraction, including the foramen magnum, right?
No, it's not a very standard concept.
Okay.
You don't need to address foramen magnum per se, because if you release the posterior calvarium as much as possible, the foramen magnum is taken care of by itself. Although still there are some workers who work on the foramen magnum too at the same time.
Right. Any questions from my co-host Libun Singh?
Thanks, Raja.
Thank you, Raja.
Yeah.
Okay.
Okay,
please.
Question? Yes. Thank you, Prof, for very nice presentation. I have 2 questions, Prof. One is, I know Prof had mentioned this is a multidisciplinary teamwork. I want to know that between a neurosurgeon or plastic surgeon, who dictate more on how the arrangement of the bone pieces, rearrangement of the bone pieces in the head, reshaping the head, who have a role in that? My second question, Professor, in distraction, how often that do you encounter fracture where you need to reapply the screw on the bone, and how do you address bony defect in the long term? Do you need to do anything for the bony defect in long term? Thank you, Professor.
Okay, addressing the first question. So let's say we are addressing a syndromic entity, let's say Cruzen, or a Cruzen, or a syndrome which you expect ICP to be the primary game changer. So you look at the aesthetics, but aesthetics is not the primary goal. The function study is the primary goal. Although my colleague would start contouring the forehead, etc. But I take the lead in deciding the fact that I need to give space to the brain, the maximal space to the brain, and keep the future perspective in vision. Now you cannot have very good contour, a well constructed contour, well screwed into place, and tomorrow he comes with a raised ICP again within a short time. So I have to keep the longest span of non-surgical window for these kids. So I leave much of space for the brain, lot of bone gaps, lot of bone windows, and neosutures, so that they do not come back with raised ICP in a very near future. So the whole idea is you want to have that 0 to 5 years of life completely covered. So aesthetics is important, because that's what delivers quality on face, isn't it? You need the children to be happy, you need the parent to be happy, but at the same time, with the neurosurgeon and the neurological aspect, we need to be happy by creating space and yeah. So because I mean, I'm say, although my colleague determines the aesthetics, I determine the functionality and the long term. I'm very critical about it. So we do not allow too much of contouring too. The next aspect is the distraction. Yes, we do have multiple situations where the screws get loosened and the bone breaks. So the choice of technique is very important. Now, if you noticed, like the Midphase, we use this Midphase transmaxillary pin. So there is no, it pulls the bone. There is no push here. So the fragile bone does not play any much of a situation. The bone is the transmaxillary pins are across the strongest portion of the bone. This is planned well in the robotic console. So we have disallowed any kind of screw misplacement, etc. And the second question, other part of your question was that the placement when you have bone holes. So we sometimes use a excess mesh or mesh so that we are able to screw it in a wider way. And very occasionally, use of shunts much earlier, or PCVD much earlier than Midphase would allow all these bone gaps to fill and bone to become stronger.
Thank you, Professor.
Is that okay? Thank you.
Yes, Professor Lia.
Okay, Professor. Yeah, I also have a question. Thank you, Professor Uda Kumara. We know the Midphase surgery is necessary for the severe airway and ocular issue, like your series in the lecture. However, the challenge is for very young children, like less than 2 years old. The face has low ossification of the facial bone, and after your distraction, if the ossification will continue to grow, because some paper mentioned sometimes it's not easy to continuously grow. So your categorization, the type 3, you have many kinds of procedure you have to perform, like a posterior distraction, frontal orbital, and then Midphase. So if you, what is your timing to decide when to perform in first, or how age you will perform in the Midphase?
So the posterior calvareal wall distraction comes in first in the syndromic children, because the ICP is a near constant issue. And the frontal orbital advancement is usually for older children. Now you have a 2-year-old coming with a raised ICP. I might gently keep the posterior calvareal wall distraction on the by the side, and you do a frontal orbital advancement first, if an older child comes to me first. and you don't have the ICP as a prominent factor. The midphase, all said and done, yes, I agree to the fact that midphase, once handled, will not grow much. That is the concern of the maxillofacial surgeons. So they don't handle the midphase until 5 to 6 years or beyond 6 years of life. So, but at the same time, if you look at the functionally, you have an airway which is constantly damaging the brain. There's a constant damage of brain happening. Does not make sense to allow that situation, isn't it? You have an airway which is the child is going into hypoxia multiple times. Child is not getting sleep. Child has failure to thrive because the multiple upper respiratory tract infections, and the child goes into multiple apneas on sleep study. That is not feasible with normal optimal growth of the brain and performance of the child. So that is why we prefer to take risk on the side of revision surgeries or possible revision surgeries and non-growth of the face rather than damage the child. I think that's where our role, I mean, as a neurosurgeon comes into play, because we should be very clear that the function of the child is the primary, then comes the aesthetics. So if at all the child requires revision surgery, that so be it. I mean, aesthetic surgeries can be performed multiple times, but once the function is damaged, you cannot revert it.
Yeah, I agree. So I saw you a very fantastic and very novel technique for midphase distraction. Yeah, it's very fantastic. But I want to know if you have met the condition for, because if the distraction pin directly from here, is there any problem for the maxillary nerve? Maxillary nerve, because maxillary come from the foramen of rotundum and then go to the pterygopalatal fossa. So, and he will run into the inferior orbital fissure into the orbital fossa and then go out from the infraorbital canal at the foramen. So if these kinds of distraction pin will endanger the maxillary nerve or not when you during your distraction?
The fact that we use ROSA is a part of all these goals to avoid damaged to the orbit, the tooth buds, and the nerve we have not taken into account. Probably like the supraorbital nerve during frontofacial. Are you worried about the the supraorbital nerve? Sometimes it gets snapped, isn't it? So the maxillary nerve might be an issue, but actually we have not taken that into account because these kids have very severely damaged, and this is of no choice.
Yeah. Thank you very much.
Thank you.
So, is there any other question from our online audience?
Not so far.
Okay.
Right.
So maybe we could move to the next topic, right?
Yeah, thank you. So thank you very much, both the speakers and chairs, for your time and support for our webinars. As Professor Shubin has updated us, there are around 960 people who have joined us live on various streaming platforms other than Zoom. And I thank you, Professor Shubin, for that. Thank you very much, both the chair and speakers, for your kind support for our webinars. So may I invite Professor Takashi Agari to say a short introduction and invite Professor Yang Lu for his lecture. Professor Agari.
Okay. The second speaker is Professor Yang Lu. He will talk to us a lecture titled Neuromodulation for Spinal Cord, from Sensory to Motor Function. And spinal cord stimulation is currently used as a treatment for intractable pain, but it was also used to treat involuntary movement disorders, such as Parkinson's disease, tremor, or dystonia before the 1990s. However, with widespread use of DBS and botulinum therapy, ACS has become largely unfocused on movement disorders. I think this is probably because the therapeutic effect is inferior to DBS and botulinum therapy. However, the performance of ACS device at that time was very limited. Recent ACS system has dramatically improved, and we expect that it will show a different effect of improving motor function than before. So I'm looking forward to Professor Liu giving a lecture not only on neuromodulation therapy for chronic interactive pain, but also on treatment for movement disorders or paralysis. Professor Liu, please go ahead with your lecture.
Okay, thanks to Professor Takashi, and thanks for introduction, and thanks for the invitation of the ACNS, and thanks Professor Raja. So my topic today is neuromodulation of the spinal cord and from sensory to motor function. I'm Yang Lu. I'm Yang Lu, a neurosurgeon with Beijing Tsinghua Chang'an Hospital of Tsinghua University, and also I come from a National Engineering Research Center of Neuromodulation of Tsinghua University. Just as the Professor Takashi said, neuromodulation of the spinal cord stimulation at first used for the intractable chronic pain. And this topic I will focus on the sensory and motor functions, neuromodulation. And because my major is the spine and spinal cord diseases. And as for the patients with the spinal cord related disorders, no matter it's traumatic, oncologic, and vascular or systematic, and even if we have cure the disease, and a lot of patients has some remained functional disorders such as motor dysfunction, sensory dysfunction, and autonomic dysfunctions. And just as that's for spinal cord injuries, and annually there are about 500,000 cases of spinal cord injuries in the world. And if it go to the chronic phase, right now there is no effective treatment to totally restore the spinal cord function. And so this field is really a hot spot, and a lot of methods has shown maybe there is a promising future, but right now there is no effective one. And first, I would like to talk about the sensory neuromodulation that is for the chronic pain. And chronic pain affecting the quality of life of patients. And the incidence rate is over 20% of the population. And from the data of the United States, and in 2010, US spent over $560 billion and in the chronic pain. And the cost is over the cardiovascular disease plus the cancer. And for my country, China, and there are about 70% of the patients who have a nervous system related diseases, they complain of the pain. And also it can cause anxiety, depression, sleep disorders, and memory loss. And for the extreme cases, and patients usually have a suicide attempt. And also there are, for the pain management, there is a 3-tier management of the pain, but the limitations there. And such as for meditation, and there is education problem, and for the physiotherapy, behavior therapy, interventional therapy, and this therapy may be ineffective for patients with chronic intractable pain. And also in some countries, and the drug overdose is really a severe issue. And the data from the United States, and in 2000, there are 40,000 cases, and have the overdose related suicide. And in 2017, and it inclined to the 110,000. For the spinal cord stimulation, this therapy has a long history, and it's developed from the gate theory that proposed by Professor Melzack and Wall in 1965. And they think that spinal cord stimulation could activate the A-beta neurons and in the dorsal horn of the spinal cord that can indirectly suppress the A-delta neurons that are responsible for the pain signals. And this is a classic theory, but it cannot explain all the patients in the clinic, but we still use it. And that the spinal cord stimulation, the most classic parameters we use with low frequency that to evoke the paresthesia of the patient in the pain area to suppress the pain. And also spinal cord stimulation regarded as the last resort therapy. And in United States and Europe, there are about 80,000 cases. And And for the indications, in United States, the first indications are FBSS and CRPS. I know, but in Europe, the low limb ischemic pain is the first indication. And after the gate theory was proposed, the Norman Shelley, physician in Massachusetts General Hospital, and he cooperated with engineer, and they developed the first generation of spinal cord stimulation. But at the time, the pulse generator is separated outside the body. So for the spinal cord stimulation indication, it's for the classic selection criteria, and we divided the patients into different tier. And for the good indications for SAS, such as neuropathic pain in leg or arm, following FBSS or FNSS, or the CRPS, or the peripheral nerve injury, or the pain-associated ischemic vascular diseases, and refractory angina pectoralis, and this is the indications in Europe but not in US, or the brachial plexopathy. It is a partial but not avulsion. And some indications we think it is bad choice for the SAS in the past, such as the spinal cord injury or the central pain of non-spinal cord regions. But these years, and we use spinal cord injury with the new parameters and new configurations that can partially solve these problems. And for my center, and we use our domestic SAS system, and which is developed by the PINS Medical Corporations in China. And also in 2020, we initiated the first nationwide clinical trial, and including the dozens of the centers. And this domestic SAS system, it is rechargeable and has adaptive stimulation according to the position of the patients. And also it can support the 16 contact electrode and the 10 kHz stimulation, and the pulse width of the 1000. And also there's one feature that is really important for us is remote programming, and which means, and after the operation, and we can adjust the parameters or configurations, and doctors can maybe in Beijing and the patients in the other city, and we can remotely reprogram the parameters. And as for the results of the clinical trial, and as first we choose the randomized withdrawal clinical trial, and that means after 3 months post-operatively, we randomize put patients in 2 different groups, and one group is withdraw the therapy of the SAS and to see the effectiveness of the spinal cord injury. And compared with the VAS score with the classic studies, and we could see that it has a significant reduction of the pain score, and above the 50%. And after 1 month post-operatively, the score is slightly increased, which is associated with the other studies. But it's different in the disease spectrum, and with our cohort and abroad cohorts. And the left is from the Medtronic data in 2006. And the most patient who choose the SAS is because of the FBSS. But in China, among 1/4 of the patients is derived from the spinal cord injury and other central nervous injuries. Let me share with you some interesting cases. And the first is, this is a patient has a complete spinal cord injury, and his pain area is just at the level of the lesion. And the upper gram, we could see that the fingers point out the pain area around there. And because the instrument of the spine, so it's really hard to do the percutaneous electrode. And it's really hard to maintain the electrode in the midline of the spinal cord. And as we put into the spine, and we could see that if we use the classic parameters that is a low frequency of stimulation, we could see that the paresthesia area cannot cover the pain area of the parents, so it didn't work at all. So we choose so we adjust the parameters to the 10 Hertz high frequency, ultra high frequency stimulation, and the pain got relieved over 50%. And also, this is really a rare case, that Parkes-Weber syndrome, and it is a congenital disease, the vascular abnormality, and since the patient was young, and the patient since 9-year old, and he undergone many surgeries and 3 vascular interventions. And Parkes-Weber syndrome is characterized of the capillary malformation and hypertrophy of the bone and soft tissue of affected limb. In this case, it's the left lower limb, and multiple arteriovenous fistulas, which is main characteristics compared with the KTS, another vascular abnormalities. And we could see that before the surgery, that is in 2020 July, and we could see there is a big fistulas that under lower the left knee, and and after the surgery, and the electrode was placed in the thoracic 9 to 10 level, and for the classic parameters, the low frequency stimulation is not worked, and so we changed to the 10 key ultra high frequency stimulation, and the patient got the pain relieved over 50%, and we have the IPG implanted, and 4 months after the implantation, and we could see that the angiography showed the fistulas gone, and we don't know why, but the pain is better, and I think the heat complaints of the left lower limb was relieved also, and we think that maybe the high frequency stimulation has rebalanced the autonomic system, and to rebalance to affect the blood flow, and may cause occlusion of the fistulas. So this case is really interesting. So just like the feature I talked before, that our domestic SAS platform has a remote programming function, and because China is a country that with a limited medical resources, and I'm in Beijing, and patients around the country will come to the mega cities such as the Beijing, Shanghai, Guangzhou, and to seek for the therapies. And also, this kind of surgery was mainly done in the mega cities in China, or the provincial capitals in China, but the patient is around China. So the post-operative programming is always an issue. And so we launched the remote programming function that doctors are in hospital, that we use a computer, and the patient at home with his smartphone and his own programmer's device, and we can remotely to adjust the parameters or configurations of the patients. And so this function was launched in 2020, and and before the COVID-19 crisis. And so it's really solved a lot of problems during the COVID-19 pandemic. So in 2020, we firstly to publish an article to introduce this system. And in this article, we introduced 16 patients in our center who use this remote programming platform, and most of them are satisfied with the function. And the main complaints, several patients complaints because of the unstable connection. And the main limitation of the function, I think, that is the digital literacy and the unstable connections. And with the improvement of the infrastructure, I think it will be better. And after that, we also extend our retrospective study and into more centers, and we have included over 60 patients and who used the programming remote programming system, and we asked what's the feel about this system, and what about the complaints of the system. And about 70% of subjects use remoting program due to the inconvenience, just as said before, and a high cost and long time of the traditional follow-up. And nearly 97% of the subjects tried remote follow-up, and about 96% of the patients of subjects recognized the value of remote programming. And with all the data we collected, we think we can use, based on the remote programming platform, and we can we can build up a precise neuromodulation system, and to precisely to manage the pain status and the quality of life of the patients of pain. And that means that with the compatible applications on the smartphone, and we can have the pain status or the quality of life feedbacks every week or every month of the patients, and we can actively to intervene and whether we should adjust the parameters or adjust the drug of the patient and to make the quality of life better of the patients. And so our next step, we will initiate a clinical trial and try to testify whether this kind of module or the platform is good for patients. Okay, next part, I would like to talk about a project we have initiated several years ago. And last year in August, we have done the first cases. And right now, the first cases have over half a year, and he has returned home. And as Professor Takashi introduced, and we focused on the epidural electric stimulation to restore the motor function of the patient. And the whole project is try to use the brain-spine machine interface and to restore the motor function of the patients. But right now, we just use the epidural electric stimulation. It is first step. And the whole project is led by the National Engineering Research Center of Neuromodulation of Tsinghua University. And the PI is the Professor Lu-Ming Li of Tsinghua University. And the clinical director was Professor Guihuai Wang, is our director. And for the artificial, we call it artificial spinal cord, because it is not like the traditional spinal cord stimulation. For the traditional spinal cord stimulation, it's kind of passive, and we just gave a parameter for the patients, and no need for the cooperation of the patient, and we can suppress the pain. But for the motor function, is totally a different story, and the patient should coordinate it and cooperate with the stimulation we give it to him, and to initiate the motor function and try to rework again. And this is the first. The system is has several features, which is really fantastic, and such as it has simultaneous evoked compound action potential recordings of the spinal cord, and it has a 32 contact electrode, which can give us precisely to locate the hotspot we want to stimulate. And the total logic is we try to stimulate the lumbar enlargement of the spinal cord under the caudal to the level of lesion, and try to use the residual circuits of the patient to initiate the working ability again of the spinal cord injury patient. And before the first case, we have testified our module on the animal model, and also to test the functions of the spinal cord epidural electric stimulation. And this is the clinical trial data, clinical trial registration. The last August, we have completed the first case, and during the surgery, we try to have the EMG monitoring of the lower limb, the muscles of the lower limbs, and try to ensure that the electrode was placed in the right location, that from the rostral to the caudal, it can stimulate the muscles we want. And with the EMG mapping, and we try the different locations of the electrode to find the best for this patient. Here is some results that this patient is a spinal cord injury patient, and for within 1 year. And before the operation, we could see it is the Asia B patient, and the lesion level is the thoracic 5. We could see that before the operation, the patient couldn't use his lower limb at all. And with the support system and the help of the therapist, and we could see the constantly reflex of the hip and the knee, he cannot use the muscle. It's 1 month after the implantation. I asked the subject to extend the knee and to reflex the hip, and he can cooperate with it. And with to combine with the rehabilitation training, and the patient can 2 months post-operatively, the patient can standing for over 10 minutes. The arms just used to keep the balance. The most weight is supported by his legs. We tried with the simultaneous monitoring of the EMG, and we get the better parameters of the 2 legs, and to achieve the better performance of the motor function. And for the 3 months, and we have the ground working training with the support of the weight support system. At first, we had the 30 kilos support of the patients, so that over 60% of the weight of the patients. And after half a year, we can see that with zero weight support, the patient can walk by his own with a walker. Right now, just each leg has 4 groups of the parameters, and the different parameters are used to achieve the different group of muscles to have the in the different phase during the working. And so simultaneously, the different leg have the different parameters stimulated. And for the summary, that spinal cord stimulation for pain is a relatively passive and one-way modulator, and so there's no need for the patient. And but the artificial spinal cord, that is epidural electric stimulation, and for the patient, and need the patient's own volition and the coordination of the stimulation and patient efforts. And we also know that more efforts should be made to understand the underlying mechanism during the motor function reconstruction, and to facilitate the coordination of the human volition and the stimulation. And it's unknown whether this coordination system could be used for pain control, bowel, and bladder functions, and we may test it in the future. Okay, that is my talk. Thank you.
Thank you. Thank you, Professor Ru. For showing your great work and giving us a wonderful lecture. You gave a lecture on the effect of the new device on improving motor function. Your work is very fantastic and inspired us very much. So the pins remote programming system is very sophisticated. As you know, Japan is a small island country compared to a country China. So it is relatively easy for patients to go to the hospital. However, due to the current spread of COVID-19, the movement, the movement of people has been very restricted. So telemedicine is very useful, and there is a growing interest in devices that can be remote controlled. I also think remote programming is very good for improving the anxiety of patients and improving patients' satisfaction who cannot go out of their house. So my question is, I think it is necessary to develop a sufficient high-speed communication network for telemedicine. There are still areas in remote rural areas that are not well networked. Is it possible to provide medical care even on a low-speed network?
Thanks for your question. So yeah, first I agree with you that remote programming can also improve the anxiety, some emotion of the patients, and we found that we look back at the data that for right now we have do a lot of the remote programming sessions and with a lot of patients, and not all the patients that have the remote programming visits to adjust the parameters. They just want to see the doctor and to check whether the machine is good and whether I have to change the drug or change the parameters, and maybe no change of the parameters, but the patient report, yeah, it is helpful. So yeah, I agree with you that it can improve the anxiety, and especially during the COVID-19 pandemic. And your question is, and for the network infrastructure, that is very important. And so for the remote programming, because it's a real-time video and parameter exchange, and so we have the speed at least is 4G. If we use a mobile connection 4G or the Wi-Fi, that is okay. And in China, most of the area is covered with the 4G, but yes, we have some rural area, that areas, these patients, just as I said, I think the main limitation is the digital literacy. And these patients usually don't know how to use the smartphones. And also the second limitation is they don't have a stable connection. So I suggested them to go to the hospitals, maybe the hospitals in the near cities, and which can support the connection requirements, and we can do the remote programming.
Can the doctor program everything remotely, or the patients actually program themselves and the doctor instruct the patient to change the program?
No, I just want to share my. Yeah, and you can see this picture. It's doctor to program the parameters, and this is the panel that we use in reality. That in the middle we could say that we can choose a different electrode, and we can change the parameters or even configurations to low frequency or the ultra high frequency modules and for the patients, and to before the discharge of the patient from hospital, and we can upload the images and into the system to keep us to follow up.
Oh, it's very nice, nice system. And when we program low frequency tonic simulation, changing position changes the strength of stimulation induced paresthesia, doesn't it? Okay. Therefore, do you program by making the patient sit or lie down even in remote control?
Mostly lie down. Yeah.
Okay. So the a motor regarding the motor function, do you stimulate the level directly above the spinal cord injury?
First, we have done one case, that is the traumatic spinal cord injury. And in the future, I think after the first several cases, we want to focus on other indications, maybe tumor or maybe after vascular surgery. I think they are also very useful and helpful for the patients, but we'll check.
Okay, so which part of the spinal cord do you think should be stimulated to improve motor function? Is it appropriate to target the posterior column of the spinal cord as in pain treatment?
Actually, it's really important and a great question that, before our project, that there are several groups in the world that in this field, and such as Gregor Coating from Switzerland, and the Susan Hakma, and from the Kentucky, and Kendall Lee from Mayo Clinic. And we have exchanged ideas with Gregor Coating on internet, and he gave me a clear-cut answer. That is, he used the electric field to stimulate the dorsal root of the spinal cord. But whether it is a whole story, we don't know. That and also the new paper published this year that Gregor Coating in Nature Medicine, and he said in this article, he said maybe some part of the spinal cord was also stimulated, such as dorsal horn or the proprietary function of the spinal cord. And we have right now, our team has done some the basic research and tried to investigate the mechanism of the this artificial spinal cord stimulation. We'll see. Yeah.
Okay. Yeah. Thank you. So regarding the simulation waveform mode, so which simulation parameter do you think is useful? We can now use not only low frequency tonic simulation, but also high frequency, burst, and more complicated stimulation conditions can be combined. So which waveform do you think is better?
You mean frequency? For the frequency, right now we use a low frequency that is below the 100 hertz. That yes, for the flexors and extensors, they prefer the different frequency. But for the you mean for the waveform we use the rectangular waveform, which is similar with the we used for pain right now. In the future, we may test the different frequency and the different waveform, and first we should to check whether it is used for animal. In human, we know that the rectangular waveform is safe and effective, but whether the other waveform is effective or safe, we don't know right now.
Okay. So is there any questions from audience?
So far, none. Professor Liang, are you here? Would you like to ask anything?
Yeah, thank you for Dr. Liu's great talk. I'm very interested about your artificial spinal cord for the spinal cord injury, because the application will be very great, very big for this population. So what's your enroll criteria for this device right now? Because you say there are many different group to start to perform this technique. So in your Beijing, Tsinghua, Chang'an hospital, so your enroll criteria, what's your enroll criteria? Like how old, what's stable, and how long of the injury time you will choose to perform the surgery?
Okay. Right now that with our experience and also with the experience with other groups, and right now we enroll the traumatic etiology, and also the patient should over 18-year-old, and the duration of the disease should be over 6 months. We think when it into the chronic phase, and also which is important that the level of the lesion should be higher than the thoracic 10 level, and which to maintain the intact of the lumbar enlargement of the patient, which is the anatomy basics and for this therapy.
Okay. So is there other questions?
There are no questions. You may conclude with your remarks.
Thank you.
Thank you.
So thank you, Professor Lu, for a wonderful presentation and discussion. And I hope that you will success in your research. Thank you.
Thank you. Thank you, Professor Takashi. And thanks for the organization.
Well, thank you very much. It was indeed very sophisticated and awesome research that you are doing, and it will be a landmark study and a solution for complete spinal cord injuries. Nevertheless, we are looking forward to your further studies in future. I would like
Thank
to
you, Professor Raja.
I would close this officially now on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I would like to thank both the speakers of today, Professor Suhas Udaykumaran and Dr. Yang Lu, as well as the chairs, Professor Takashi Agari and Professor Moli Liang, for the kind time and support for the ACNS webinars. A special thanks to Professor Shubin for broadcasting this on the WeChat channel. And today we have around 960 people who have joined us live. A special thanks to my co-host Liu Bun Sen for joining me today. So until we meet again for the next webinar, it is bye-bye from all of us. Thank you very much for joining.